Yeah, let me know when you're okay. Good to go?
Yep.
Okay. All right. So the it starts. Okay. So the first slide, I highlighted some of the things that I think were pertinent to humeral shaft fractures and insertion and origins of muscles. But first, we could start on the lower left of the screen. So the epiphysis is located here on the humerus. You have the growth plate, the metaphysis, and then what we'll be talking about today, which is the shaft or the diaphysis. If we go up here to the anterior view of the humerus, I highlight the anatomical neck, the greater tubercle, which is the insertion point for many of the rotator cuffs, such as supraspinatus and infraspinatus, the lesser tubercle, insertion for the subscapularis, and here's the surgical neck of the humerus. And if we move a little farther down or more distal on the humerus, you can see here's the crest of the greater tubercle, which is the insertion point of the pec major, which later we'll find to be a deforming force with humeral shaft fractures. And moving a little farther down, the deltoid tuberosity, which is the insertion of the deltoid. More distal on the humerus, you have the lateral supracondylar ridge, the condyles, medial and lateral, and then you have the lateral epicondyle, which is the origin for a lot of the extensors of the forearm, the capitulum, which articulates with the radius, the trochlea, which articulates with the ulna, and the medial epicondyle, which is an origin for many of the flexors of the forearm. And if we move on to the posterior view of the humerus on the right side of the screen, we can go down here to the infraglenoid tubercle, which is actually the origin of the long head of the triceps. Moving here, which is the radial groove. This is very important in humeral shaft fractures because, as we'll learn later, radial nerves can be in. There is a possibility of radial nerve entrapment with humeral shaft fractures, the distal 1/3. And then again, moving down to the groove for the ulnar nerve, which lies posterior to the medial epicondyle. We're not talking about distal radius fractures, but could be a problem if there are distal radius fractures, distal humerus fractures, I'm sorry. All right, so moving on to muscle origin and insertions. Again, I just highlighted some of the more common muscles that are major deforming forces in humeral shaft fractures. So the pectoralis major inserts at the lateral lip of the intertubercular sulcus. You have the deltoid tuberosity, the deltoid inserting the deltoid tuberosity again, and the coracobrachialis, which inserts on the medial side of the humerus. Moving more distal, now we can talk about the origins of a couple muscles. So the brachialis has its origin on the anterior distal part of the humerus, the brachioradialis distally on the lateral part of the humerus, and then moving even farther down, again, the common extensor origin on the lateral epicondyle, and then the common flexor origin on the medial epicondyle. And again, moving to the posterior side of the humerus, I talked about the long head of the tricep, which is not visualized here, which originates from the infraglenoid tubercle. Here you have the lateral head of the triceps, which inserts superior to the radial groove. And here you have the medial head of the triceps, which originates inferior to the radial groove. I just want to make sure I'm not missing anything. Okay. And again, I just highlighted a couple important neurovascular structures with humeral shaft fractures. So again, the axillary artery enters into the arm, and when it crosses the lower margin of the teres major, it changes its name to the brachial artery. So we're not talking about superior or surgical neck fractures of the humerus, but with those, the profundi circumflex humeral artery is at risk of injury. But we are talking about humeral shaft fractures, so the profundi brachii artery is actually at risk with humeral shaft fractures, since you can see it courses posterior to the midshaft of the humerus here. Moving over to the neurovasculature, the axillary artery is normally not at risk with a humeral shaft fracture. The musculocutaneous nerve, which innervates many of the flexors of the forearm, the median nerve, which is the dominant arm of it dominantly innervates the anterior compartment muscles of the forearm, the radial nerve, like we said, which is at risk of entrapment with humeral shaft fractures, innervates many of the extensors of the forearm, and the ulnar nerve, which courses posterior to the medial epicondyle. It's a dominant nerve to muscles of the hand and the flexor carpi ulnaris. And just my last two slides introduce humeral shaft fractures and treatment options. So humeral shaft fractures can be described by location. Here, these are midshaft fractures. So they could be displaced they could be angulated, or they could be comminuted. And there's a couple patterns that are depicted here with these images. So you have transverse fractures, which are an A. You have oblique or spiral fractures, which is B. And you could have angulated or comminuted fractures with angulation, which are depicted in C. And again, like I mentioned before, radial nerve entrapment can be seen with distal humerus fractures. And the next slide is my last slide. This has to do with treatment options. So for us, we're going to be talking about functional bracing. And there's a couple indications for functional bracing. So the fracture has to be minimally displaced, and there has to be less than 3 centimeters of shortening. There has to be less than 20 degrees of anterior and posterior angulation of the humerus, and there has to be less than 30 degrees of varus and valgus angulation. And some surgical indications. So if there is an open fracture, if there is a floating elbow, segmental fractures, or polytrauma or vascular injury, then surgical intervention may be required or indicated. So one option is ORIF with a plate. Then you could have external fixator, such as if there has to be frequent changing of the dressing. And lastly, you could have intramedullary nail. And these are, those are my citations.
All right, thank you very much, Pasquale.
So stop sharing.
So we can move on to the first paper, the classic paper by Sarmiento. And then if there's any questions while it's going on, we can bring them up, or we can talk about everything at the end. I don't know if anyone
has any questions, or someone's going next.
Can you hear me?
Dr. Kai, we can't hear you.
I can hear them. So maybe, PJ, I don't know if you have your volume down.
Sorry, I was muted. I couldn't.
Can you hear me?
Volume was down. Yeah.
Yeah.
Todd, can you just maybe, PJ, I thought that was awesome, and thank you for doing it. Maybe PJ's last slide, if you just take them through varus, valgus, and like angulation, like how we define that based on parameters, so we're all talking about the same thing.
Yeah, can you bring that back up?
Yeah, no problem. Let me share that. 1 second.
So,
okay.
So you brought up this these guidelines for treatment, which are exactly correct, and those are the guidelines that people go off of. I think it's important to realize that even though the human mind wants to have classification systems that decide how to treat something one way or the other, it's not always based on very hard science. And this less than 3 centimeters of shortening, less than 20 degrees of AP angulation, and less than 30 degrees of varus valgus was from a paper in 1967 that was underpowered and came to very questionable conclusions, but it's the still 50 years later most quoted guidelines for how to treat humeral shaft fractures. So it's always important to take things with a grain of salt, even though even if it might be dogma in our practice. So what this all means is it doesn't matter what the initial displacement is of the fracture. It could look like it's 90 degrees in varus or valgus. What this is referring to is after you place them into some sort of splint or cast, do some sort of reduction, how does the alignment of the fracture look in the AP and lateral planes, which can be very difficult x-rays to get because your humerus is not really fixed in space and things could be out of line. So when you talk about shortening, you would measure from one end of the fracture to the other how far short it is. In terms of A to P angulation, you would have to take a lateral x-ray, which is easier said than done. You can either raise the person's arm up and put a plate underneath it. You can do a transthoracic lateral X-ray, which is very difficult to do in the ER. And patients don't tolerate it very well when their arm is broken. But what you're looking for is to see that angle between the two fragments, which is usually an apex dorsal angle because of the deforming forces there. And then varus valgus is also very important. And the vast majority of the time, you'll see these fractures go into a varus deformity because of the pull of the deltoid on the proximal fragment. And it's very important then to, when you splint them, to try to put a valgus mold on it. However, the vast majority of these patients are going to end up going to a functional brace like the one you have on the right side there. And these parameters are really most important to measure once they're in that brace to see how it's going to align once they start to heal that. And I think some of that will make more sense after the next paper is presented with Sarmiento.
Mention that varus valgus, because that's not something intuitive, where varus means that the distal segment's pointing toward the midline, or the apex is away from the midline, whereas valgus, the apex is on the inside and it goes to the outside. And when we talk about anterior posterior, we're talking about which way the apex of the fracture is. So if you look at an angle, it's in that short portion. And that's just when you're describing these fractures. That was good.
All right, who's got Sarmiento?
I've got Sarmiento. Do you see my screen? You guys see my screen?
Mm-hmm.
Okay. Hey guys, so my name's Wilfredo. I'm one of the rising M4s. I think the M2s are still undedicated, so I just took this paper up. So paper is titled Functional Bracing for the Treatment of Fractures of the Humeral Diaphysis. It's been written by Dr. Augusto Sarmiento. He's a practicing orthopedic surgeon at the University of Miami, and this paper was written in 2000. So Dr. Sarmiento's sort of claim to fame, he's a pioneer behind this concept of functional bracing. And the idea is that it's bracing only the fracture site, and you're able to leave both the joint above and below free to move. So it's a cylindrical brace that's placed around the fracture site, and it compresses the fragment to be able to reduce it such that anatomically it has like good outcomes. And I'll go into that a little bit more in a bit. But for the specifics of the actual brace, he said that 2.5 centimeters below axilla to 1.3 centimeters above the medial epicondyle is how much you want the brace to extend, and laterally you would like it to extend from the level of acromion to the level of the lateral epicondyle. And so, as I mentioned, it gives you full range of motion at the level of the shoulder and the elbow, and it creates this sort of quote unquote pseudo hydraulic environment where the soft tissues themselves are what's compressing the actual fragment site. So, for the study, Dr. Sarmiento followed 922 patients at an indigent clinic that they had, and 620 of those patients they were able to follow up relatively long-term. So for those patients, 465 of them had closed fractures, which is 155%. 155 had open fractures. And so the average patient was a 36-year-old male with a fracture along the middle humerus. And so the method that they followed in this paper was to place the patients in the first week in a coaptation splint seen right here. And the goal of that was just to be able to immobilize the joint as much as possible for the first week, just while the patients were able to subside or get through their pain. Usually about 1 week, the patient's pain had subsided enough that they would be able to place them in the functional brace, which is seen here. And as I mentioned before, it gives you full range of motion here at the elbow and at the shoulder and at the elbow. And when they put them in this functional brace, they taught them how to use these sort of pendulum exercises to be able to limit the atrophy that patients would have because they would still be able to move their elbow and their wrist. And importantly, they taught them not to abduct or elevate their shoulder because that could reduce the sort of anatomical reduction of the fragments and would increase the angulation of the fragments. So In these patients, the 465 of them that had closed fractures, only 7 of them had non-union rates, around 2% rate. And for the patients that had open fractures, only 9 of them had non-union rates, a little bit higher at around 6%. And it took about 9 weeks for the patients in this functional brace to show radiological and clinical evidence that the fracture had joined. And for the open fractures, it took a little bit longer at about 14 weeks. So these are some of the pictures of some of the patients that they were able to follow. So this one right here is a comminuted fracture from a gunshot. And this was the first image taken at the initial presentation. And so here, this was taken 2 weeks after with the functional brace, and you can see that some of the fragments are starting to reduce, and they're joining a lot closer now. And same thing here with this fracture right here. So this was taken at the initial presentation, and this was taken 6 months when they removed the functional brace, and you can see that it's really healed very well. Even they had some subluxation here at the glenohumeral joint, which was reduced by itself. So for these patients, the deformity that was seen long-term, only 70% of them had less than 5% angulation in the sagittal plane, and 75 to 80 of them had varus or valgus deformity of less than 10 degrees. So that was considered really physiologically and aesthetically acceptable, as opposed to having them to undergo like surgery. And in the paper, no matter the fracture location, whether it was proximal, in the middle, or distal, it didn't really have any difference in the outcome of the functional bracing, since there were such low rates of non-union. So the paper, what the point they try to make is that non-operative management still really remains the standard of treatment for patients. They have excellent union rates, especially with the closed fractures. So as we saw here, it's like only 2% of the patients that had closed fractures had non-union rates, and 6%, a little bit higher in the open fractures. There was also really acceptable angular deformities, both physiologically and physiologically, and what was it again? And aesthetically acceptable. And because they have their shoulder and their elbow are still free to move, a lot of the daily activities there, they don't have as many limitations. But some of the issues that I did see with the paper is that they had really limited long-term follow-up. So if we saw here, only 67% of the patients were able to be followed up until the fractures actually healed. Because this was like an indigent population that had sort of low SES and low health literacy, they didn't really follow up once the symptoms had improved, even if the fractures hadn't healed yet. And so the paper sort of makes assumptions on the long-term outcomes that I didn't feel could really be made if they didn't follow them up that long. They said that the range of motion would be acceptable and long-term when they really didn't follow patients up that long. And one of the facts about humeral fractures is that it's got a bimodal distribution. In young patients, it's seen with high energy impacts, and it's seen a lot also in the elderly with more low energy impacts because of like their osteoporosis, osteopenia. And the paper didn't include too many elderly patients, so I don't know how generalizable really this was to the elderly population. And so that's it for the paper.
Great job, Wilfredo. So you brought up some really good points about some of the limitations of this paper. Sarmiento is pretty much known as the guy who pioneered these braces, and usually we don't even refer to them as functional braces in the clinical setting. We just call it a Sarmiento brace. And he did a lot of great work with these, but there are some really large limitations to this study that are still coming into question today, 20 plus years later. The first of which that you mentioned, which is important, was that they only had 2/3 of the patients following up, because this is their free outpatient clinic for their uninsured patients, and the follow-up there is truly horrible. Like you mentioned, the patients are more young patients, less so. There's not really any elderly patients included in this, so that would have been interesting to see. This is from like Miami, where like you saw there's 25% of the patients had open fractures from gunshot wounds, which is not really the same clientele that most people are taking care of around the country. And these people, a lot of them, even if they come to the clinic, they're not coming back a second time. So I really have a lot of questions about how they even obtained a lot of this data. I think it was probably a lot harder than they gave it credit for. The other thing is that they did mention some things that are really important. For one, in their non-unions, they mentioned that they saw distraction between the fragments and in half the patients, meaning that there was a gap on the x-rays between the fracture fragments, which is something that people have since studied, and we're going to see in one of the other papers what the significance of that is. And then there was also, and aside from the number of patients who followed up, the duration of follow-up was not consistent, and it's not really 100% clear if any of these patients that didn't follow up were going to seek treatment elsewhere. Does anyone have any other comments about this one?
I just had a quick question about the GSW wound.
Yeah.
With the functional bracing, like, is that still indicated for like a functional brace? Because even that last X-ray on the right, like, is that an acceptable outcome for functional bracing of GSW? It just looked like the humerus wasn't healed.
Yeah, so that was not, I don't think that was the final follow-up X-ray for that one.
Yeah, that was only at the 2-week mark that was done. And so
there's another figure later in the paper that shows it a final follow-up being healed. So that's a good question. And so we like to categorize gunshot wounds in terms of their energy level. So, a low velocity gunshot wound would be like a handgun, which is what most of the gunshot wounds are. They're not really high energy like assault rifles or anything like that. And for low energy gunshot wounds, we actually consider them to be closed fractures, because as the bullet's going through, it's doing so at a high speed and at a very high temperature, and it's considered to be sterile as it's going through whatever it goes through. So even though we wash those up and clean them up in the ER, we are not taking those to the OR immediately to clean those out like we do other open fractures. And so just because there was a gunshot wound for a humeral shaft fracture, that is not a hard indication to fix it or to wash it out. So if we saw a fracture like that today, we'd probably still be treating it the same way they did, by cleaning it up and putting them in splints, and then as long as the alignment's acceptable, continuing with the functional brace. That's a good question, because a lot of times these fractures look horrible on x-rays. They look like you need to fix them immediately, and oftentimes the ER will call us frantically saying, when are you guys taking this guy to the operating room? We got all the labs and admitted them to medicine. And then we say, oh no, we're going to put a splint on, they're going to go home, and they're baffled. So it's one of those things in orthopedics that ends up being a lot better than it looks on the x-rays.
100% with Todd. And I think, one way to think about it is, more surface area, the better for healing. So in the diaphysis or the middle of the bone, if it's just smashed, to a certain extent, that's probably a good thing for the patient to heal. You'll see later that the ones where it's just a short transverse fracture, where there's not a lot of surface area, those are the ones we struggle with. But when you get into the articular areas and you see something that's commented, then it's a real disaster, because we're trying to get that articular surface as near perfect as possible. So that one conservatively, and there's a very, very high chance of that uniting and doing well. And even if the radial nerve is out with these blast injuries, they usually come back too.
And you don't have to go fishing for the bullet fragments the vast majority of the time. So let's go on to the first contemporary paper. I think that was Newhouse. Was that the next one?
Sure, that's me. All right, can you guys see my screen?
Mm-hmm.
All right, So I looked at a paper that sort of followed up the Sarmiento papers called Risk Factors for Fracture Mobility, 6 weeks after initiation of treatment of mid-diaphyseal humerus fractures. So this is by Newhouse in 2014 at Mass Gen. And essentially the sort of rationale for why they did this study is that previously other risk factors for non-union have been described, those primarily being the AO subtypes of A3, which are transverse fractures, and AO type A1, which are the spiral fractures. And also open fractures are more likely to have issues with non-union. Aside here, I have just a quick display of the AO subtyping that we're talking about. So basically, the initial paper that made me think about this was the Sarmiento paper on functional bracing. If you remember from when it was being presented, 16 patients had non-union, and of those 7 were people where there was a persistent gap noticed. Additionally, another study by Koch et al., they had noticed that when there was a persistent gap between the 2 fragments, those patients were much more likely to be indicated for operative treatment eventually. And also the writers of the paper had just noticed that in their clinical practice, that they had noticed that persistence of gap made them more likely to pursue surgery for these patients. So what was done in the study is that this was a retrospective study of closed humeral shaft fractures, primarily of the A2 subtype and the A3 subtype. And they were all at the middle third of the diaphysis. And these had to be patients who were not operatively treatment and not treatment with not a periprosthetic fracture. So what they did is when they looked through, they measured the angulation, the translation, and the gap in all of the retrospective fractures that they pulled up. So I have here on the right side is when you're looking at the diaphyseal line, here's how you measure the angulation, and over here is how you measure the translation. And they in their paper show you how they measure the gap, which is by creating 2 parallel lines between the fragments and measuring the distance between them. So what they did initially is they looked at the ER notes and noticed that these patients were sometimes functionally braced, but most of the times they were placed in a coaptation splint. And then within 2 weeks, these patients were inevitably sent to an orthopedic surgeon and they were placed in the functional brace. And then they followed them for 6 weeks. And they looked at if the surgeon at the time noticed functional mobility after that time period. And those where functional mobility was noticed, they were ultimately treated operatively. So here's the overview of the patients. There's just a few things I want to point out. So overall, the rate of radial nerve palsy was 8% in the population. And like Dr. Kant mentioned earlier, all these patients went on to have their radial nerve palsies resolved upon follow-up. And 19% had concomitant injuries in another area. The duration of follow-up here was also on the shorter end. It was like 11 weeks median. And so the main thing they had noticed that were statistically different between those who healed and those who were still unstable at 6 weeks were females were more likely to have to require operative treatment, smoking history, as well as of their measurements in the ER room were the gap. So they took these 3 factors, which were smoking, sex, and gap, and then did a bivariate regression analysis on it. And they essentially found that with these 3 factors, there's an increased risk of maintaining fracture instability at 6 weeks. So with smoking, there's a 6-fold increased risk. With female sex, there's a 5-fold increased risk. And for gap, they noticed that with every 1 millimeter increase in the gap that was on imaging, there was a 40% increased chance for fracture instability. Overall, they had 20% of their patients who didn't achieve union at 6 weeks with bracing. And over here on the bottom right corner, this essentially shows you all the patients who were treated with the functional bracing, going from bottom to top. That's the amount of gap that was noticed on imaging. And on the left were those who didn't have any fracture mobility, and then the right are the ones with fracture mobility between the 2 fragments. So the main crux of this study was that people with A2 and A3 fractures should initially get braced and then surgery pursued on them if there's still fracture mobility at the time. One of the kind of issues with the study, though, is that while they identify these risk factors, it kind of been previously described that outcomes for these patients are the same whether or not surgery is done immediately or after 6 weeks. Even though we kind of now know that this is a risk factor and it's something to watch out for, surgeons are still not going to use operatively as soon as they see them. They're still going to be braced or followed up later. And again, the other major finding was that with larger fracture gaps, you're going to be at increased risk of non-union. And they also note that people who are smoking should counsel to stop smoking in order to promote healing. And that was basically that.
Awesome. Really good presentation. So I think a few important things to take away from this one are to understand why they chose the 6-week time point, which is because there is substantial evidence showing that if you have a lack of union of the fracture on x-rays and motion at the fracture site at 6 weeks, that it's highly predictive of going on to an eventual non-union, which if you take the literal definition, does not happen until 9 months after the fracture. But you'd be hard pressed to find someone that would wait that long for a fracture like this, which is very uncomfortable to walk around if it's not healed. And then also it's important to note that they were doing all of these gap measurements, either in the emergency room or at the first measurement in the Sarmiento brace. So usually within the first couple of weeks. So this paper really gives a nice way to predict which patients are going to be at higher risk, even early on at 1 or 2 weeks, who's going to be at higher risk to develop a non-union at 6 weeks and further. And then one interesting thing that we could take away from this one is that they only had 80% documented healing rate in this paper. And we just got finished talking about a paper where they had 98% healing. So clearly there's some differences in these patient populations and how the studies were organized, especially given that this was a retrospective study at a major institution that collects all this data on patients to begin with. So you can have people measure the same exact things and get 2 different answers in this field.
A great summary. I mean, my only point clinically is if it's a bigger patient and they have a bigger arm, sometimes determining if the fracture has motion at it is somewhat difficult to do. Like, I think it's a little bit of a judgment. I mean, and you know, you might see a little bit of a haze of callus, and unless it's grossly moving, you know, sometimes I've been fooled thinking something's healed, and then I see them 6 weeks or 3 months later, and it's clearly not. So it's a little bit arbitrary if there's, quote, motion at the fracture site. Todd, have you had any experience with that?
I saw a patient today who did not have a large arm and had motion at their fracture site, but I can definitely imagine that being difficult to see if they do have a large arm. And then they actually postulated, I don't know if it was in this paper or the other one, why there would be any difference for females or such a large difference. And they postulated that could be due to breast size creating more of a varus deformity in the arm, which I don't know, maybe. I don't know if you have any, I don't know if differential like estrogen levels could have possibly anything to do with this in terms of bone healing, but yeah, I think that would make it more likely to heal.
That's what I was curious. They didn't show that if you broke those down by weight, it would be interesting because, as you said, Todd, that you see some of these rather large women who have the large breasts and everything, their arm just goes into varus. It's hard to control the fracture without in those bodies. It just drapes over the side of their body.
Mm-hmm.
So I wondered the same thing when I saw the results of the paper. Probably the most likely reason. I've certainly seen it clinically, and I'm sure you have too, Brian.
Those proximal third ones always scare me, but I think you also have to tease out how many of these are high energy versus low energy. To my point before, you know, usually the young male with the high energy injury is going to heal, and your 60-year-old female that, you know, you just cross your fingers that you're going to get her through it. So that probably has something to do with it as well. I don't know if they controlled for the energy when they looked at the sex differences.
All right, so why don't we move on to the last paper and then we could finish our discussion.
All right, I'll just pull it up. Can everyone see the screen?
Mm-hmm.
Okay. Hi everyone, I'm Yesha. I'm one of the rising M4s, and I'm going to be talking about the Serrano paper, which is modern results of functional bracing of the humeral shaft fractures. So the study design was really a multi-center retrospective analysis that included 1,182 patients from 9 different institutions from 2005 to 2015 that had closed humeral shaft fractures that were initially treated with the functional bracing. And so their whole purpose of this study was really to analyze the rates as well as the reasons for surgical conversion of the humeral shaft fractures that were initially treated with functional bracing. And the outcome that they looked at was whether or not they converted to surgery. So this is pretty much the timeline of what they used when they were conducting the study. First, the patients would arrive in the ED or the fracture clinic, and they would undergo a reduction of their fracture. So as mentioned in the other presentations, the reduction would be less than 30 degrees of the varus valgus angulation, less than 20 degrees of the AP, and no more than 30 millimeters of the shortening. After that, they were placed in for immobilization in the splint. And then 1 to 2 weeks following their presentation, they would then reassess the reduction and then transition them into a functional bracing. They would then assess for clinical and radiographic healing at the 4-week, 8-week, 3-month, and 6-month mark. And at the 3-month mark, they would really try to identify individuals that would be at high risk for non-union. And at that point, they would start to monitor them at shorter intervals. Patients who ended up having their reduction was specific for kind of not having the non-union, they would try to re-reduce them in order and follow up with them to make sure that they aligned properly. So they had 4 major surgical conversion indications. The first one was clinical signs of non-union, which involved pain with extremity use and gross motion at the fracture site, just like we were talking a few minutes ago, as well as radiographic signs of non-union. And this indicated just no radiographic changes for 3 months of follow-up. The second indication was loss of compliance with the functional bracing. The third one was loss of the initial reduction, and the re-reduction that they tried was not able to be achieved. The fourth indication was if they had persistent radial nerve palsy after 3 months of the expectant management. The results of the study showed that most individuals, about 70% of them, had successful functional bracing of their fracture, and they showed union at an average of 15 weeks. They did have about a 30% conversion rate to surgery, and most of which was due to non-union. So that was about 18% of these patients. And that usually they were seeing the non-union at about the average of 23 weeks. And 7% of these were due to loss of initial reduction. And so they saw most of these patients ended up needing surgery at the average 5-week mark. 3.4% were due to the non-compliance with the bracing, and they required surgery at the 4-week mark. And 1% of patients really had the persistent radial nerve palsy after the 3-month mark, and so they required surgery for that. They also found certain risk factors that indicated a higher rate for surgical conversion. They found females were 1.7 times more likely to develop non-union than males if they were Caucasian or if they were employed. It also depended on the specific type of fracture that they had. So if they had a segmental or comminuted fracture, or if they had butterfly fractures. If the fracture was in the dominant hand, that also increased risk. And if they were alcoholics or if they were smoking tobacco, that also increased their risk. And like we were mentioning before, the mechanism of injury, whether it's high velocity or low velocity, that really also matters as well. And pedestrian versus auto was really the highest risk for surgical conversion. So for conclusion, given that 70% of these patients ended up healing with a functional bracing, their recommendation is to first do functional bracing as the initial treatment for the humeral shaft fractures. And then because 30% of their patients did require surgical conversion due to those 4 major reasons, we just need to counsel patients about their chances of failing conservative treatment, especially if they have those given risk factors.
Great job. Question for you, Yesha. What do you think, why would people who are employed be more likely to be converted to surgery?
So it could be a few things. One of them could be if their job requires them to use that dominant hand, they're going to use it, especially if they have different socioeconomic factors involved, that they have to keep going to work, they can't take off, but it could also be non-compliance from wearing the brace if they don't want to show that they have the fracture. So a few different things involved.
Perfect. So I think it's really important to remember that even though these braces do a very good job in healing fractures, it does take a very long time for these, and these patients are wearing a very uncomfortable brace for weeks and months at a time. And that non-compliance factor is very real. And even if patients do comply, they're not always happy about it. But also, it's important to recognize that the surgeries for these fractures are not without complications. And that's why we take every opportunity we can to avoid the surgeries. It's, for if you are doing an ORIF, it's a big incision. You have to identify the radial nerve, and that could be at risk. There's still a chance of non-union. You could have a hardware failure. Same thing with the nails. You can have shoulder pain, rotator cuff injury. So no matter what treatment you choose, you have to weigh what the pros and cons are. But I think what this paper does a really good job of is identifying they looked at 9 different level 1 trauma centers. So it's really hard. They didn't make up any of this data. And they found that if you combine 9 different trauma centers, there's a 30% conversion to surgery. So, that's hard to refute. And it makes you really question the validity of that data from Sarmiento from 20 plus years ago. And then I like that they broke it down into these different categories as best they could, given that it was a retrospective analysis. But, it's always difficult to take people's words for it in the literature. So I think that this was really important for showing across the board that it's not just one institution running into this issue.
You made a lot of good points. I mean, on the margin, because I'm a hand surgeon, I like working around nerves. I'm probably a little more aggressive than most. If you look at the sports, like the sports guys and the hand guys, see most of these. And, I probably fix more than my sports colleagues were, just because I'm comfortable and I'm okay with the bigger incision and the plating across there. Like if patients are complaining about, and there's varying degrees of complaining, but, some, this, okay, fine, I'll fix you, versus someone else that might, pacify them and say, let's go another 2 weeks or 4 weeks, and then fix them. The one thing that's not mentioned here, Sarmiento said everybody got good shoulder motion. And, I debate that. That's a study that I want to look at, especially in the proximal shaft fractures, because they wear the Sarmiento brace for a while. It takes them a while to start therapy. I feel like I'm chasing that shoulder motion. And a lot of people, they end up at 110 or 120 degrees of motion, which is fine, but it's certainly not 170 degrees. And those that I plate that get moving right away, their results are usually fantastic. So I think, that's something that, we at Robert Wood, because we do see a fair amount of these, we should really be diligent and look at it. And even they said, they do fine if you fix them later at 3 months. That might be for the more diaphysis, but those proximal third, even if I have to go back and plate them, I just can't get their shoulder motion back. So I don't know if you've seen that, Todd or Dr. Gadd, if you want to comment, but post-op shoulder motion has been a challenge in my practice when I don't fix people early.
I think probably the patients more than the physicians ignore shoulder motion. They just look at the injury and they focus on their elbow, and they have easy use of the arm, even with a functional brace. But nobody, a lot of times they're not instructed to, even in a Sarmiento, you can start pendulum exercises. The fracture starts to stabilize. You can do wall climbs. So I know when I've taken care of them, I actually focus on the shoulder early and try to get it moving early because of what you said. Because once you lose the shoulder motion, it's hard to get it back, even if you do surgery. So that's a good point. I think that should be an important point that you make in your treatment protocols when you're treating them non-operatively. Once you do surgery, then you start moving everything. Everybody thinks about everything, but that for some reason we kind of just forget the shoulder in non-operative management.
So I think everyone did a really great job tonight, especially considering this is the first time we did this. The reason I chose this topic in these papers is because I think it's important to understand that our field is not black and white, and that even though there are people who said 20 years ago that this is the way it is, it's always important to be critical of everything, including the newer papers, because nothing's perfect. Moving forward, I think that you guys can use this opportunity however you want. If you want to change things around or add or subtract items from these journal clubs, that's well within reason. I think that it could be challenging as med students to reach out to attendings to ask them to participate in something like this. But it's really we just need one attending for each one. If you guys ever have any issues reaching out to attendings or you feel uncomfortable reaching out to them, let me know. It's totally fine. I can talk to anyone. And then we'll also try to have resident involvement throughout all of these as well. And if anyone has a suggestion for topics moving forward or has a question about whether a topic would be good, then I'm happy to help you out with that as well. Any other comments or questions for anyone?
I think Todd's point about the topic, Todd's picked out a great topic for today, because this is, something that you'll, as medical students, you'll be on rotation and you'll see these cases in the emergency room and you'll see them in the operating room, but it's not esoteric. This is, something that we see on a very regular basis. And so as you guys move forward with this journal club, that's really what you want to focus on, is just fight the urge to get anything too esoteric, because it's probably going to be a little bit over your heads and something that you're not going to see frequently, as opposed to like the most basic of problems that you'll see on rotation and help you with your learning experience. So like to me, just the perfect level of complexity, I think, for this particular venue. That was a great choice, Todd.
All right.
So from the preparation to the execution, this was really flawless. So thank you for stepping up and doing it. And I think we have a great template for going forward. And for the guys and females that presented tonight, that you all did a fantastic job. I'm really impressed with what you did.
Yeah, great job, guys. So at this point, I think that myself, Dr. Cott, and Dr. Gatt are going to sign off. And if you guys want to talk about who you're going to appoint to be the liaison for this and how you want to structure this going forward, you can take this opportunity. And you guys all have my email address if you ever want to reach out if you have any questions. So thanks for all showing up tonight and participating. And I'll see some of you in July.